Good evening. It is my great pleasure to introduce our guest speaker for today's webinar, Professor Sampath Paththinige. Professor Paththinige holds a thorough knowledge and expertise to our session today, holding an impressive set of qualifications, including MBBS, MSc in Clinical Genetics, Masters in Medical Education, and a PG certificate in Medical Education. He currently serves as a professor in anatomy and a clinical geneticist at the Faculty of Medicine and Allied Sciences, Rajarata University of Sri Lanka. Professor Sampath has made a significant contribution to the field of medical genetics in Sri Lanka. Today, we are privileged to listen to his talk on looking for genetic causes of inherited disorders. Before we begin, let me remind you on the housekeeping rules as usual. Please make sure to rename yourself in Zoom with the name that should appear on your participation certificate. And towards the end of the lecture, a link will be shared in the chat box with a Google form. Please fill it out. To obtain the certificate, you must attend the lecture for a minimum of 45 minutes and you should complete the given form. The Google form will consist of 3 multiple choice questions. You should select only the correct answers in the checkboxes. And the correct answers to the post test and your certificate will be sent to you via email after you submit the Google form. And also the answers for the questions will appear just after you submit the Google form also. And please keep your microphones muted throughout the session. And if you have any questions, kindly type them in the chat box and the questions will be addressed later. So I hope you will find the session, today's session informative and useful. So now I invite Professor Sampath for his lecture on looking for genetic causes of inherited disorders. Thank you.
Right. Good evening. Thank you so much. And I would like to first thank the Sri Lanka College of Specialist Family Physicians for inviting me to do this session. And yeah, it's really nice to see some of my good friends and students in the audience. So just to brief you what I am going to talk in this session. So it is, when you look at the topic, looking for genetic causes of inherited disorders. So the topic itself is a very broad uh, thing because the inherited disorders. So to name them, so that would be a long list of disorders. But as I have been advised and what I've been thinking of, not going into the details of the clinical aspects of all these disorders, I'll be focusing on the common things that common disorders that you will encounter in the routine clinical practice, and focusing mainly on the genetic diagnostic aspects and what you will be you have to focus when you do the genetic counseling or when you try to refer these patients for specialized genetic testing. So with my experience in the genetic clinics, in the clinical genetic setup, so when we work in the genetics clinic, so we see the patients who are referred to us throughout this whole spectrum of life. Starting from birth towards the adult life, not really starting from birth, even before birth. We get a fairly large set of individuals or the pregnant mothers who are referred to us because the clinicians have diagnosed that there is a suspicion of a congenital abnormality in a baby. So they want us to look for a genetic cause. And at the time of birth, a clinician, doctor will see that the child is born with dysmorphic features or some congenital abnormalities, internal organ abnormalities, or maybe even the genitalia are not well differentiated. The baby is having ambiguous genitalia. So, that kind of situations, we get the patients immediately after birth. And as we go on, in the early ages, So we get a fairly large number of patients for the genetic analysis who are the children who are having the developmental delays, the intellectual disabilities, and as they go on, some learning disabilities as well. So then towards the teenage years, so that is another peak that we have where we receive a lot of teenage girls who we are um, presenting with delayed puberty or the primary amenorrhea. So then there is a very large peak of patients, the referrals that we get with the couples who are having the problems with the fertility, the infertility, and the recurrent pregnancy loss. And throughout this spectrum, we also get the referrals for a lot of different disorders, the suspected genetic disorders, right? Even towards adult life, some adult onset disorders. And again, there is a fairly a large number of patients who are referred to us uh, for the genetic evaluation for the risk of getting a cancer. So when we get this type of patients, so there are different lines that we are thinking of whether this is something related to the chromosomal disorder or a genetic disorder. But when we look at all these different referrals, so I thought of that we can easily categorize them into three common groups: the patterns of genetic diseases that we encounter in our setting. So, there is a fairly large number of chromosomal disorders that we encounter, and with another significant proportion of single gene disorders, and then the inherited cancer syndrome. So the session here will be mainly focusing on these three areas. So then finally, I'll talk a little bit about the different genetic diagnostic methods and where you can go. Send the patient to get these tests done. So first, looking at these chromosomal disorders. So as we all are aware, the chromosomal disorders, so there are numerical chromosomal abnormalities where there is an abnormal number of chromosomes, right? Most commonly the Down syndrome. Of course, the Turner and the Klinefelter syndrome is there out there with the large numbers. And then there is a set of structural chromosomal abnormalities. Most commonly, what we see is the chromosomal translocations. So even these disorders, for example, if I take the structural chromosomal abnormalities, even though each translocation is individually rare, so when we collectively take them, so that is, there is a significant number of patients out there. So for example, I have done the collective submit. I have published a report with the collection of 277 chromosomal translocations within a period of 10 years in a one genetic referral center. So that is a fairly large number, which shows that they are not really rare. They are out there. They are, but some of them are not getting really diagnosed. So we'll be looking at some of these conditions in detail. So especially I was asked to talk a little bit about the Down syndrome because of course that is a very good reason for that, because the Down syndrome is the commonest chromosomal abnormality that you will encounter as a doctor anywhere in the world, right? So so you have to know about it, and I'm sure you know the basics about it. And the thing is, to diagnose a baby with the Down syndrome, you don't need a genetic test. You don't need the karyotype. So that is why sometimes, so even when we have a patient with Down syndrome, when you have all these dysmorphic features with white saddle gaps, with the transverse crease, the simian crease, and all the abnormal facial features, you might not think about the getting a genetic test done. So what you see here is a karyogram. The genetic test is the karyotyping. So generally in most of the cases, it is trisomy 21. As you see here, there is three copies of chromosome 21. So that is what we generally see. But what in my practice and in your practice as a doctor, the commonest indication that you think of doing a genetic test is also a Down syndrome, but it is not just to diagnose the Down syndrome. So the commonest occasion that I was thinking about doing a genetic test for a patient or a family is when a couple come to me and tell that they already have one child with Down syndrome and they want to have another child. So that is the occasion that you have to think of getting the genetic testing done, because Down syndrome is not always due to this trisomy 21 due to non-disjunction. So it is occurring by chance, but it is not always like that. So that I'm sure you know, because there are occasions where there can be a silent, or we call it a balanced chromosomal abnormality, most commonly a translocation, where one of the chromosome 21 is translocated into another chromosome. So these parents are perfectly normal because there is no loss or gain of the chromosomal material. So that is why we call it a balanced translocation. But when they produce gametes, so they will produce the gametes which have an imbalanced chromosomal composition. So this is a situation where a genetic abnormality is hidden in a parent and it is inherited into the child. So the importance is in this situation, so there is a chance of recurrence. There is a risk of recurrence. The family is at a risk of getting another child with Down syndrome. And the risk is higher if the one of the parents has this kind of abnormality where the two chromosome 21s are joined together. So that is a 21-21 translocation. So two chromosomes are stick together. So they are inherited together. Right? So the risk is in this type of situation, these parents, these families have, so all the live born babies that they will have in the future will be having Down syndrome. So there will be some of the fetuses or the embryos will be which will be lost, right? So those are the ones who are trying to develop without a chromosome 21. But when a child is born to this kind of couple, so all the live born babies, all of them will have Down syndrome. So that is the risk of this condition. So whenever we have the couple coming and telling us that they already have one child, so usually what they say is, so doctor, we have one baby who is having this Down syndrome. So the child is now about 3-4 years old, and they think that the child needs some support when he grows up. So they are thinking of having another child to support this child. So in that kind of situation, so you need to do the genetic testing. So if you go for the genetic testing of the parents, you might have to do the genetic testing of both. But the easier or the cost effective way is to do the genetic testing of the baby. So that will show whether the baby or the child is having Down syndrome due to non-disjunction or a translocation. So this thing can happen even in other autosomal trisomies. You know, the other two autosomal trisomies are trisomy 18, that is Edwards, and trisomy 13, the Patau syndrome, but usually they do not survive the adulthood. So they are usually we do not see them in the community, right? But even in those situations, if they have a history of a child who are born with the other trisomy syndromes, so you will not have that child to do the genetics testing. So in that kind of situation also, it is always good to do the karyotyping of the parents, because there can be the balanced chromosomal abnormalities which gives rise to those conditions. So then the other two commonest chromosomal abnormalities that you would see are the Turner syndrome and the Klinefelter syndrome. The babies with Turner syndrome, they have some characteristic features at the time of birth with a lot of edema or the swollen feet and hand and some additional skin in the neck, so the neck webbing. But what we very commonly see is they are usually missed at the time of birth. And there are a lot of patients, I can't tell them the patient, there are a lot of individuals with the Turner syndrome and Klinefelter syndrome out there in the community without the diagnosis, right? And they are diagnosed at a later age. So very commonly we see a lot of girls who are diagnosed with Turner syndrome when they were referred to us with the delayed puberty, the primary amenorrhea. And most of the males who are diagnosed with the Klinefelter syndrome are diagnosed even after their marriage. So they are being investigated for the subfertility, and the investigation shows that there is abnormal the seminal fluid analysis. So when they were referred for the genetic analysis, so we diagnosed the Klinefelter syndrome. But sometimes they look very perfectly normal when you look at them outside. So these are the things that you would see in the general practice event. So there will be these patients without a clear genetic diagnosis. Right? So then going into the other component, the structural chromosomal abnormalities. So if you can remember your medical student days, so when we talk about the structural chromosomal abnormalities, the commonest condition that we were talking is about the Cry-Duchat syndrome. So this is where, if you remember, so where the child's cry is like, so we call it a cat cry, which is due to the deletion of the chromosome 5, right? So there's an interesting case. So we had a child. So these are the real cases that I have seen personally. So this particular child with the typical features of Cry-Duchat syndrome, and when you do the karyotyping, we saw, so in the Cry-Duchat syndrome, we expect a shorter chromosome 5. One of the chromosome 5 has to be shorter. But here in this case, we saw, so one chromosome 5 is in fact long, right? So we are not sure how this happened. So what we did was we did the karyotyping of the parents, and what we saw is, so there is a part of so there is chromosome exchange between the chromosome 8 and the chromosome 5. You can see the chromosome 8 is broken here, and it has been translocated into the chromosome 5. And this abnormal chromosome 5 is inherited to the child. So that is the one which appears longer here. And that has a missing piece of chromosome 5. So that is like a chromosome at the deletion of the chromosome. So because a part of the chromosome 5 is missing. So that is why the child is having these typical features of Cry-Duchat syndrome. So what I want to highlight here is sometimes. So the clinical diagnosis is obvious. So you can just by looking at the clinical features, you can diagnose a lot of genetic conditions, the chromosomal abnormalities. But in all of these cases, there is the possibility that some abnormal structural chromosomal abnormality, some structural chromosomal abnormality in the parent has caused this problem. So it is not a de novo in the child. It is something inherited. So even when the clinical diagnosis is obvious, still there is a place for the genetic analysis. And that will give a lot of information, the important information for the genetic counseling, and also that will prevent the recurrence of these disorders in the families. So still looking at the structural chromosomal abnormalities, so all these are from the published articles that I have published. So I have obtained the permission to show all these pictures for the educational purposes. So this is a case of a child with severe developmental delay with multiple congenital abnormalities, right? And when we do the karyotyping, we saw that there is an abnormality in the chromosome, the 14 here, right? So when we do the parental karyotyping, we observe that there's a translocation between the chromosome 7 and 14. So there is an exchange of material. A large part of chromosome 7 is broken down here and it is translocated into the chromosome 14. So I use the case very commonly in all my sessions because of this interesting pedigree, right? Because this shows where we have failed as the practicing clinicians. Because when you look at the pedigree of this baby, so this is this baby who is 2 years and 4 months at the time of the genetic testing. And when you look at the history, you can see this mother had 2 miscarriages, first trimester miscarriages, and one live-born baby, a boy who died at 2 months of age. But still, until this baby is born and she is 2 years and 4 months, there is no genetic testing done. So some might feel bad if I say that this is a preventable birth because but I have to tell that so the birth of this child with a lot of abnormalities, with a lot of suffering to the child and the family, so could have been prevented if this couple was investigated earlier. So you don't need to fulfill the typical the case definitions of the recurrent pregnancy loss or the typical uh, uh, protocols to look to go for the genetic diagnosis or to do the thing that has to be done, right? So it is the having the high degree of suspicion, right? So with 2 first trimester miscarriages and 1 early death of a child, so that is a case where the clinicians, the doctors who have been attending to the needs of these patients should have thought of doing some genetic test, right? So if this has been done earlier, they might have easily diagnosed that the mother is having this translocation and the unfortunate birth of this child has been could have been prevented. So that leads into the next set of abnormalities that I want to discuss. So that is about the recurrent pregnancy loss. So this is the report that I've been telling you about. So this is a collection of 277 individuals of chromosomal translocations, right? So in this collection, so there were 91 translocation Down syndrome cases. So you can see they are not really rare. So these 91 babies are out there in the community, 91. And then again, you can see there's a significant number of patients with the chromosomal translocation who are referred to us with recurrent pregnancy loss and subfertility. And the interesting thing you can see here is when it is the recurrent pregnancy loss, the contribution of male is very less. But in subfertility, it is relatively higher. The reason why for that, the genetic reason is what is said is when there's a structural chromosomal abnormality, usually in the process of spermatogenesis, when the sperms are producing, if there is a chromosomal abnormality, it stops, right? So there is uh, the spermatogenic process is arrested. So they do not produce enough sperms, so they usually present with subfertility. But in case of females, so even when there is a chromosomal abnormality, the oogenesis process happens. So oogenesis continues, they produce the ova, but when the fetus or the embryo is produced, that they cannot survive. So they are lost. So they have the recurrent pregnancy loss. So that is why, that is the reason for the explanation for this. So when it comes into the recurrent pregnancy loss, the contribution of the chromosomal abnormalities from the father's side is much less compared to the females, right? It can happen, but it is relatively less. So the next thing I'm going to talk about is this recurrent pregnancy loss and subfertility. So as you see, so it can be due to the structural chromosomal abnormalities. When you have a patient who is telling that they have the repeated miscarriages, so probably you might not wait till the third one to occur. So if you have talked with the couple, especially a mother who had two previous miscarriages, you can I understand the suffering that she has gone, for the mental, the psychological effect that she had. So you don't need to wait till the third one to happen to send her for the genetic testing. So just look at the family history, and so even without a family history, there might be a possibility of there is a place of getting a genetic testing done. So because it might give uh, a reason why this is happening, because most of the suffering is because they have done a lot of different tests and still they don't know why this is happening. So if you do a genetic testing, right, if you refer this couple for the genetic testing, so they might find a reason and that will help them to make up their minds, right? So then another thing that we see is, so when you, sometimes this patient will come to you with a karyotyping report, which shows a thing known as polymorphic variants. So these are not really the mutation or abnormalities, these are variants. So they are common abnormalities in the population. But what has been shown by research, especially with the embryos or the couples who have been going through the IVF, in vitro fertilization, is, so there are some variants in the chromosomes where some parts of the chromosomes are longer or they are inverted, right? So there is a bit of an enlargement of these the stalks or the satellites of the chromosomes. So there are these kind of abnormalities, and there is evidence that there is a high prevalence of these abnormal variants in couples with the subfertility or the recurrent pregnancy loss. It is not a very totally uh, conclusive results, or so uh, it is not really established thing, but it has been observed. So there are a lot of papers which are published, even some papers from Sri Lanka, which shows that there is a higher prevalence of these variants in among the individuals who are having the subfertility and the recurrent pregnancy loss. So you might see these things, so you might have to explain these reports when they come with these reports to you and ask what this is. So these are not really abnormalities as such, they are various, they are out there in the community, but when they try to reproduce, they might cause problems, right? So then the other genetic thing, genetic cause where we are thinking about in subfertility and recurrent pregnancy loss is the genetic thrombophilias, right? So things like factor V latent, so there is a prothrombin or factor 2 mutations, right? So there is MTHFR, so they which lead to the elevated levels of the homocysteine. So also the things like the deficiency of protein C and protein A, so they are there. But some of these do not need a genetic test. For example, the protein C and the protein S, so you can quantify and see whether there is a deficiency. But some of them will need a genetic analysis, especially the things I list here in the presentation. So those are the genetic tests that you can ask for. So they are available in the country. So there are genetic thrombophilia panels which are available in any genetic center in the country. So they will be doing these tests. So usually this panel contains these three: the factor V latent, the prothrombin, the factor 2 mutation, and MTHFR. So they will give an idea whether the mother has any of these mutations which will cause an increased risk of thrombosis, so the placental thrombosis, which will lead to the recurrent pregnancy loss. So that leads to the next set of disorders, the rare single gene disorders, because the genetic thrombophilias, they are usually the single gene disorders, right? So of the single gene disorders, the so of course, the list is numerous. We can go, I can list about 100 single gene disorders, so that which are out there. But the commonest thing that we encounter, and the commonest things that you encounter as practicing doctors, are the thalassemias, both the beta and the alpha. The beta by far, so you will see more cases of beta thalassemia, or the carriers of beta thalassemia. A lot of patients with hemophilia A is out there, and then you will encounter a lot of neurogenetic disorders, the late onset or the adult onset disorders like Huntington's, the spinocerebellar ataxias, and then children or the teenagers with Duchenne muscular dystrophy. And I added the familial hypercholesterolemia here. Right. So because uh, yeah, so I just got distracted because I got a question in the chat box. I'll answer it later. Right. So why I added familial hypercholesterolemia here is so because I've been doing some research on that, and you might be, as practicing doctors, you might have also observed there is a very high number of patients uh, who are getting ischemic heart disease at very young age. And when you do the lipid profile, you see highly elevated uh, cholesterol levels, and they have a significant family history, right? So so in that is typical of a familial hypercholesterolemia. Early onset ischemic heart disease, extremely elevated levels of cholesterol with a significant family history. So there are a lot of patients like that, and we are not sure whether that is really a type of familial hypercholesterolemia. In fact, some of the studies that we have done, we have seen that there are some mutations in the LDLR gene, LDL receptor gene. So there are some novel mutations that are not have been reported ever in anywhere in the world. We have found some mutations, right? So it is a possibility. So there might be the single gene disorders like that that we need to investigate, right? And that can be done in our country. So the question is, what are the genetic government genetic testing centers in Sri Lanka? So I'll answer that question, right? But at this moment, what I want to tell is the genetic testing of all these disorders that I have mentioned here. So that is possible in the country, right? So if you refer these patients for the genetic diagnostics for one center, usually, especially if you send these patients for academic center, which is located in a university setting, if they cannot do the test, they will tell you, right? So this is done in this particular place. Please refer that patient there. Or they will do that. They will take up the patient, do the genetic counseling, and they themselves will refer them to another center, right? So but all these genetic testing is possible, right? So so going into some of the common single gene disorders, right? First, about beta thalassemia. So we know that there are different phenotypes: the beta thalassemia major, who requires the regular blood transfusion, the intermediate, and the minor, and which are the carriers, right? So which is a single gene disorder, right? So which is caused by the mutations in the HBB gene, right? And we know when you do the pedigree analysis, so that is a autosomal recessive type of inheritance. I'll not go into the clinical details because that is not the focus of this lecture, right? So the thing is, for to diagnose beta thalassemia or to detect a carrier of beta thalassemia, you don't need a genetic test, right? So you can do that with HPLC. So the first thing will be doing the full blood count, which will show the low MCV and MCH, and then the blood picture, which will show the characteristic abnormalities, right? So then do HPLC, which shows the absence of HbA and the elevation of HbF, HbA2, and so on. So you don't really need genetic test to diagnose beta thalassemia or to detect a carrier state of beta thalassemia. And there are so we can detect the carriers, and we issue a thing known as thalassemia horoscope, right? Thalassemia horondom for the people who are planning to get married, because we don't need the two people with pink cards to marry because they are the carriers, right? But the molecule, if you need a molecular genetic testing, for example, there might be cases the inconclusive. So there can be cases where the hematological test or the HPLC is not very uh, uh, give a very strong evidence of the beta thalassemia, because sometimes there might be different hematological causes which coexist. The beta thalassemia existing with alpha or other type of thalassemia like that. So in that case, or sometimes if you need the very precise genetic diagnosis. So because if you detect what is the mutation in the family, so you can screen. So you don't need to do the whole set of tests again for other members in the family. You can just test for that particular mutation only, right? So we have identified what are the common Sri Lankan mutations for the HPB gene. So you can ask for the screening for these common Sri Lankan HPB gene mutation, which is done in a lot of centers in the country, right? So which will give which will establish the diagnosis of beta thalassemia with the precise genetic diagnosis, right? The thing which is usually going missed is the alpha thalassemia, because the alpha thalassemia, as you see in the previous diagram, right? As you see, the alpha globin genes are produced by 4 copies. So there are 4 genes which are produced in the alpha globin chains and 2 genes produced in the beta one, right? So they are depending on the number of deletions or the inactivation of genes. You have different. The patients will have different abnormalities. These 2 conditions, the most severe forms, when there are 4 deletions or 3 deletions, so they are very characteristics, and the specialist will detect them. So immediately after birth, right? So with the hydroxytalis or HPH disease, with jaundice, the hepatosplenomegaly. But what we have observed is, so there are a lot of patients, especially in these areas where we know that beta thalassemia is endemic, like in the north central province, northwestern province, and somewhere in the Uva area. So there are cohorts of alpha thalassemia as well. The special thing about this is usually the hematological test and the HPLC are not really diagnostic, right? So they do not really direct you for a precise diagnosis, right? So they have a microcytic hyperchromic anemia type of blood picture, but it is not really well established clear picture like beta thalassemia. So in that case, usually the genetic testing for the alpha thalassemia is useful, right? So especially if the patient tell that they have a problem, so if you can ask for the different clinical features. If there is a family history of a baby born with HPH disease, or a family history of the hydroxytalis, like that. So you can ask the question in the way that the patient understand. So there is a place to screen for the alpha thalassemia, because there can be silent carriers for the thalassemia trait with 1 or 2 the alpha gene deletions, and the possibility of screening the patients for the alpha globin gene deletions is there, right? So there are a lot of centers, the genetic centers in the country are doing the alpha thalassemia common deletion screen, right? So it is available. So these are not relatively cheap test, right? Compared to a lot of other very expensive genetic tests, right? So the patients can be referred to get these things confirmed. Right? So the other thing, as I told you here, that you will encounter is the hemophilia, right? So you might encounter patients with hemophilia who have the severe pattern with the spontaneous bleeding, a moderate pattern who have the bleeding with the minor trauma, or the mild uh, phenotype where they have the bleeding after severe kind of injuries. They do not have any spontaneous bleeding, right? So usually, so this is characterized by the reduced factor 8 clotting activity, right? But what you need to remember is the factor 8 clotting activity, right? So, and so usually what we do is we assess the clotting activity of the factor 8 and we assess the von Willebrand factor. So usually von Willebrand factor is normal, and but the factor 8 is low, the activity is low. So so that will establish the diagnosis of the hemophilia, right? So that way with the clinical picture, but it is not always indicate that the patient has a genetic abnormality. So because, for example, if you want to screen a patient, screen a female whether she is a carrier, whether she carries this, right? So these assays, the factor 5, factor 8 and von Willebrand factor assays, so their results will not give you any established diagnosis, because you cannot diagnose it along with these factor levels, right? So, so that is why it is especially in case of females, because you know this is a X-linked recessive disorder where the males are affected and females are carriers. So all the daughters of the affected males become carriers, right? So and the females transmit it into the males, right? So there is a 50% chance of transmitting it in the male. So yeah, so just uh, think try to revise what you have learned about the X-linked recessive inheritance. So there will be a lot of the female carriers. So you already know that there is a patient with the hemophilia A, and you need to screen. You need to test whether the females in this family are the carriers. So they're doing the blood test. The clotting factor assays will not be really useful there. So you might need to go for the genetic testing. So to do the genetic screening for the uh, genetic mutation, the pathogenic mutations of the FAG, right? So the important thing is to draw a good family history, so you can easily mark the people who are carriers here. So for example, in this case, so this person here is a carrier, should be a carrier, right? So then this one should be a carrier, and all these has to be carriers because ultimately there is the affected male there, right? So the genetic testing has a place in detecting these carriers, right? So especially this would be important in case of females, especially when they go for the pregnancies, when they plan for pregnancies. So the establishing the genetic carrier state of the hemophilia would be useful for the obstetricians to take some precautionary measures. Right. So uh, that is about the common or the rare single gene disorders. I did not go into all the details, right? So uh, I just talked about the thalassemia and the hemophilia A. But as I told you, there are a lot of other single gene disorders where the genetic testing can be done, right? Like as I told you, for the Duchenne muscular dystrophy, Huntington's, for hereditary hemochromatosis, Wilson's, or those type of disorders. So you can get the genetic testing done and the genetic confirmation done in Sri Lanka itself, right? So then the third common set of inherited disorders that you as practicing doctors will encounter, so are the inherited cancer syndromes. Right? So that is increasingly we see the referrals for this condition. So what is the genetic basis of inherited cancers is generally for a cancer to occur, so we need to have both copies of the genes, both alleles mutated. Because when there is a one gene mutated, usually the other gene, the gene products of the other allele, has the ability to. So the cells have a very efficient mechanisms to block the effects of the mutated gene, right? So usually we need the both copies to be mutated, so that we call this a two-hit hypothesis. So just one hit is not enough. So you need to have two hits, right? So, but what happens is when a patient already have inherited a mutated gene, right? So that is a hereditary cancer. For example, there is a mutation in the BRCA gene. So that patient needs only one copy to be mutated because one is already mutated. So that is why they have an increased risk of getting cancer. So that is the very briefly. So that is the basis of the inherited cancer syndrome. So they get the cancers early. So they get cancers with uh, less environmental exposure, right? So the common cancer syndromes that we see usually in practice are the hereditary breast and ovarian cancer syndrome, HBOC, right? And then the colorectal cancers, which are due to the hereditary non-polyposis colorectal cancer, or we call it a Lynch syndrome, or the familial adenomatous polyposis, right? So these have a very clear established genetic roles. So in the etiology or the causation of these cancers, right? So these are the common things, right? So that we encounter, especially we see a lot of cases of HBOC, the breast and ovarian cancer syndrome. Right? The special thing, so uh, I'll not going into all those, so I'll just take HBOC as an example. So you will see that there is all these, most of these cancer syndrome except a few, so they have autosomal dominant pattern of inheritance where all the generations are affected and they get the cancers at an early age than the general population. So usually in case of breast cancer, so that is before the age of 50 years, right? And they will have ovarian cancers or the cancers in the prostate, the pancreas, right? The cancers in both breast, right? Or two cancer nodules in the same breast. And when a male comes with the breast cancer, so that kind of situation, so that generally indicates, right? So there is a possibility of inherited cancer syndrome in these patients, right? The special thing about these inherited cancer syndromes are they are not produced by a single gene. So, yeah. So in one patient, it could be a single gene, their mutation. But when we take the population, so there might be multiple gene mutation producing the same type of cancer. The simplest would be the breast cancer caused by BRCA1 and BRCA2, right? But of course, for the breast cancer, there are many other type of genes as well. For example, if you do the BRCA1 and BRCA2 for a patient with a clear family history of breast cancer, sometimes it might come negative because they have the mutations in certain other genes, right? The oncogenes or the tumor suppressor genes, right? But when you see the other type of cancers, for example, the colorectal cancers, you can see there are so many genes that are involved, so many mutations in different genes. So usually the single gene testing will not be much effective in this type of situation. And you might need to go for a panel, right? So for example, in breast cancer, the initial step would be the BRCA1 and BRCA2. So there are panels where both are assessed together, right? And then there are multi-gene panels, for example, for the lung cancer, the prostate cancer, so in the colorectal cancer. So these are available. They are done in Sri Lanka. So these panel testing are there where several genes are screened or they're analyzed together. So they will look for the specific mutations in all these different genes, right? Or the other option is go for the sequencing of the entire exome. Exome is so that is the sequencing of all the exons. You know, the genes have the exons and introns. Exons are the ones which codes for the proteins, right? So those are the protein coding areas. So there are the sequencing procedures where you can analyze all the exons of all the exons in the entire genome, or you can go for the whole genome sequencing even. Usually, when we think about the clinical utility, the whole genome sequencing does not, it is not much superior, right? Because the whole genome will include the exons and introns both. But introns, I can't say the introns do not have any effect for the diseases. They have, but the major effect for the exons. But the whole genome sequencing is much costly than the exome sequencing, because the analysis part, the genetic analysis part for the whole genome sequencing is much higher. So it is more costly, right? And this the exome sequencing is possible, right? But it is costly, of course. For example, so in the Colombo Medical Faculty, it is done, but it is 125,000, right? But there are people who go for these testing, right? So because that gives a lot of important information, so they can plan their health, the future health, right? Especially when they have a lot of the family members with cancers, they might go for this testing to see whether they have this the mutation in them or not, right? When we explain the things, sometimes the people refuse the test because they think that knowing that they have the risk is additional psychological burden to them. So it's their choice, right? But we can explain them and they will decide whether to go for the exome sequencing or not. And sometimes, of course, there are the occasions that because it is the entire exome, so entire gene set is a test. So we'll identify the risk for some additional disorders, not just for the cancers, but some additional diseases that they might develop in the future, the Alzheimer's, the things like that. So so we when we do the genetic counseling, we ask them whether if we get to find this kind of other additional abnormalities other than cancer things, so whether you want to know it or not, right? So that is the patient's choice, right? The important thing that I want to highlight here is the genetic testing for the inherited cancer syndrome is not targeted gene testing. So it is generally you have to go for the panels, right? The simplest would be the BRCA gene, so it's just two. But sometimes you will miss some of the cases, the inherited breast cancer cases, if you just analyze the BRCA1 and BRCA2 only, right? Because there might be some other so as you see here, the breast and ovarian cancer, the BRCA1 and BRCA2 is here, which will increase the risk of breast cancer by about 50 to 70%, right? So, but still you can see so many other different genes. And there are gene panels which test all these genes in addition to the BRCA1 and BRCA2 as well. Okay? So, so those are the different options that can explain to the patients and patients can detect it. But of course, you have to tell the cost and the things. The special thing is the clinical utility. So how useful this genetic test would be for them, right? So that is actually the most important thing that you need to think about when you order a genetic test, because these are not free of charge, right? So they are not done free of charge. So the patient will have to bear the cost, and sometimes they are very, very expensive, right? So you need to really explain whether there is a real value the clinical use of getting these tests done, right? I might say even for sometimes so one of my patients, so they ask for a familial hypercholesterolemia. So is there a real value for doing these tests? So he has a very strong family history. So what I say is, of course, that they can decide, but my opinion is, so if the patient has a familial hypercholesterolemia, right? So there is a very high risk of early onset ischemic heart disease, right? So that is a deadly thing, right? So the people can die of that. So you have to balance the risk, right? So with the cost involved, right? If the patient can afford it, so uh, good to have get the genetic diagnosis established. So other thing is the clinical utility means, so when you get the genetic diagnosis established or the genetic risk established, so if is there a possibility of taking preventive measures? So there should be the possibility of taking preventive measures. Otherwise, there is no point, right? It's just knowing that you have the risk and you can't do it. If you can't do anything, so there may be no point in doing that. So that will be just additional psychological burden. So you need to think about all these factors, right? So, so coming back into my the initial slide. So, as I told you, so we get the patients from all these spectrum of disorders in with the genetic etiology. So, when we get these disorders, we think about two lines: whether it is a chromosomal defect or whether it is a genetic defect. And depending on our line of thinking, we might order different type of genetic test. If it is a chromosomal disorder, the karyotyping is the easiest one, or I must say it is one of the cheapest tests. Not the cheapest, but compared to a lot of other genetic testing, so the cost is less. Or you can go for a higher level, higher resolution, right? So with the molecular cytogenetic method, or the finally up to the sequencing level. So this shows the resolution of these tests. You can see the karyotyping has the lowest resolution because you see the chromosomes. You don't need the see the gene level, right? But when you do the exome sequencing or the whole genome sequencing, you can go up to the nucleotide level. But that doesn't make the karyotyping any uh, uh, less important, because still the karyotyping is used to diagnose the commonest congenital abnormalities or the inherited disorders that we see, the Down syndrome and a lot of trisomy syndromes, the monosomies, right? The structural chromosomal abnormalities, they are there, right? So, and the important thing about the karyotyping is that it also like gives us a whole genome view. When you do a karyotyping, when you have a karyogram with you, it shows the entire genome of the patient. So all the genetic material is there in that picture. Even though with a lower resolution, the entire thing is there. So it has a very important place, right? Even with the introduction of all these very high level, high resolution genetic tests, the karyotyping is still very widely practiced, and you will be ordering that. The problem in with the karyotyping that we have, especially I'm at a periphery, I'm Radhapura. So the problem that we have is remember, so most of the other molecular tests, so we need the blood samples in the EDTA bottles, so you can freeze it and transport it. But for the karyotyping, we need to collect into the heparinized tube, and you need to transport, or you need to culture it at least within 3 hours, right? So what we say, you need to transport it into the lab within 3 hours, right? So in the peripheries, that is the issue, right? So, but now there are nowadays there are in a lot of major cities there are collection centers of these genetic labs. So there are collection centers. So where they take the blood sample and immediately culture it in that particular lab in the collection center, and then transport it for the analysis to the central lab, right? So there is a problem with the karyotyping. So yeah, so if you are in a place where you can send them into the lab, right? Set the patient into the lab, better to send the patient to the lab. So they will take the sample and culture it there, right? And if you are planning to transport, so before taking the blood sample, you have to arrange a transport, right? Because it has to reach the lab within 3 hours and you can't freeze it. No, don't freeze it, right? So you can put it, generally you have to transport it in room temperature because the karyotyping need the white blood cells to be alive because we need to culture them, multiply them, and then we take the chromosome out of the karyotyping. So as a practicing doctors, just remember it. So the karyotyping so had that problem, especially for those people who are working in the peripheries, right? So, but nowadays, so the problem is settled for some extent because, but that is in the private sector because most of these private sector genetic labs, they have the collection centers, right? So they will collect it and culture it there. But usually the analysis is done at the major the labs only, right? Because these are the analysis part need a lot of expertise and experience. Right. So this genetic testing can be done. So I've been telling you about the lifestyle approach in the genetic disorders. So we are at the different places in your life, in the life of a patient, where the genetic disorders will manifest or they will present. And genetic testing is also done at these different places, right? So the pre-implantation genetic testing, so that is usually done in the assisted reproductive methods when the IVF is done, right? The prenatal genetic testing is there, so it can be in our setting. Very commonly it is done with the amniotic fluid, right? But remember, there is a non-invasive perinatal testing which can be done with the maternal blood, right? Because the maternal blood has a fetal genetic material. So you take a maternal blood sample of the mother, and assess. Especially this is done to assess whether the fetus is having a trisomy, right? Down syndrome, Edward, Patau, right? But the problem with the prenatal genetic testing in our setting is even though we diagnose it, by law, there is no chance of terminating those pregnancies, right? So, but the couples might go for the different options, right? So I can't just promote any one of those here. But the possibility of doing the perinatal genetic testing is there. Even the non-invasive perinatal testing is done. So it is costly than it is more expensive than doing the perinatal testing by the amniotic fluid. But when you think about all the additional cost, right? For example, for do the amniocentesis, uh, the mother has to be admitted to a hospital, right? So usually these are done in private hospitals, so they will have to stay in the hospital. So there will be charges, the hospital charges, the procedure charges, and when all these add up, sometimes the non-invasive testing will be the would be the best option, right? So because that is just taking a maternal blood sample, right? So then we have the newborn genetic screening. So that is again available. The important thing is, so this newborn genetic screening can be done for a lot of inherited metabolic disorders. And now there's a lot of information that a lot of these metabolic disorders can be treated, right? So they call them the treatable intellectual disabilities. If there is a precise genetic diagnosis, they can be corrected. There is just a replacement of the molecules that are deficient. So you just need replace the enzyme which is deficient or the other the biochemical substance which is deficient. So they are treatable, right? So so there are some interesting papers which are coming on these treatable intellectual disabilities which have been neglected, and these children have suffered due to their intellectual disability because they don't have a precise diagnosis. But nowadays there are a lot of genetic screening tests, so you can order right? If you think that the child has an intellectual disability due to a metabolic disorder, so you can refer these families, the child, to the genetic centers, and they will do the screening. Sometimes the screening is the test is not done in the lab itself. They will send it to the different lab in a different country, but they will get it done somehow, and that will give a lot of useful information about the treatable conditions, the conditions that can be treated so the baby's condition can be improved, right? So I've been talking a lot about the diagnostic and carrier testing. So in summary, so you can use the genetic testing to diagnose diseases in a patient with clinical features, for the screening of a newborn, to detect the carriers, so even for the prenatal test, or we can use it for the asymptomatic young adults, for the adult onset genetic condition, for example, Huntington's, or the hereditary hemochromatosis, right? Now, the hemochromatosis, usually the clinical features manifest after about 40, 50 years, but they will be having the mutation and they are gradually accumulating iron, right? So if you have the genetic diagnosis and if you know that you are at risk, you are going to develop this, so you can do a kind of a little bit of a control of the diet, reducing the dietary iron intake, right? Of course, without damaging the others. So if there is a possibility of taking some precautionary or preventive measures, establishing the genetic diagnosis for these asymptomatic patients is important. But usually for these adult onset genetic conditions, we do not rush and I don't send the children to be screened for for these disorders, because we generally wait until the proband, the tested individual, reach the consenting age, because knowing that there is the risk of getting this disease would be additional psychological burden. So the person himself or herself should decide whether to get this test done or not, right? So usually we do it after they reach the adulthood, right? So that is about this test in the asymptomatic adults, right? So then the we can test for the susceptibility. So it is not that 100% that the patient is going to develop the thing, but there is an increased rates, right, for the cancer syndromes. And we have a lot of genetic tests to predict the drug response, right, especially for the cancer treatment, the KRAS, and so those type of tests. And of course, not for the inherited disorders, but the genetic testing is also done for the forensic testing, especially to establish paternity and some of the legal purposes, and even for the HLA typing and so on. So there are a lot of users, and all that is done in the country at different centers. Not all the single center do everything. For example, there are no government centers which do the paternity testing. You have to go for the private labs, right, to do that, right? So, but usually when you do get the report, they generally write it that this is not for the legal purpose. So there is a kind of a statement, right? So telling that you can use that for any legal purposes, right? So yeah, so this is a kind of a answer for the question that I got. So what are the different genetic diagnostic centers that we have, right? Uh, the Genetic Diagnostic Center, the Human Genetics Unit of the Faculty of Medicine, it is so there is the oldest genetic center, right? So it is established in 1983, right? So that is 41 years back, right? By Professor Rohan Jayasekara. So now it is known as the Center for Genetics and Genomics, which do a lot of most of the genetic tests I mentioned here, from the karyotyping to the exome sequence, it is done, yeah, in the human genetics unit. So that is the question is what is the um, yeah where are the main government genetic testing centers located in Sri Lanka. So that is the main government center. Of course, there are some additional tests which are done in Ragama Medical Faculty as well. For example, they have been doing a lot of prenatal testing earlier. But while I prepare for this lecture, I just contacted the geneticist who was doing these tests there, and what she said is, so with the current economic crisis, economic situation, they are out of the chemicals and the other things that they require. So now they have stopped some of those tests, right? So there is a genetic unit in the Kalaniya Ragama Medical Faculty as well. And there are a lot of genetic clinics in the hospitals now, so which they will refer the patient for the genetic diagnostic services, but the government hospitals, right? So they do not have such a genetic diagnostic labs, except the Thalassemia Center, which is doing some work in Kurunegala. But most of the well-established private hospitals, I don't want to mention the names of those, right? The large private hospitals which are there in and around Colombo. Now, almost all of them have genetic labs, which do different types of genetic tests. You can just contact them, right? And ask whether they are doing this particular test, right? This is not a comprehensive list. So there are some new labs which has been established, right? So for example, this non-invasive prenatal testing, you can just Google non-invasive prenatal testing Sri Lanka, so that will show what are the labs which are doing that, right? So that information is there. So I'm allowed only to talk about the Center for Genetics and Genomics, where I have been trained on genetics, right? So which offered a lot of services, genetic services, and a lot of different tests, right? So for example, so when you go to the medical faculty, Colombo Medical Faculty website, so there will be a link to that, so you can see what are the different tests, and the contact information is there. You can just contact them and ask the cost of that. And generally, this is not advertisement, right? But the genetic lab of the Colombo Medical Faculty offers the karyotyping as uh, so that is the cheapest there, right? So they still do the karyotyping for less than 10,000 rupees, but in other places it is about 15,000 or more, right? And the most expensive one would be the whole exome sequencing, as I told you. So it is about 125,000. So and the good thing is that yeah, they provide the comprehensive genetic counseling, right? So yeah, you can just go and talk with, because there are separate days for the different types of genetic disorders, for the hematology, the cancer, the routine, the chromosomal disorders, so the skeletal dysplasias, eye genetics, so those type of things. So there are separate days. So you can just contact the center and refer the patient there, right? I'm not there now, right? But I've been trained there, so that is why I'm sharing it. And I know there is a genetic clinic which is established in the Lady Ridgeway Hospital, and now some of the postgraduate programs, like the medicine and pediatric, they have the specialty training on genetics. So in the near future, there will be the specialist in genetics in some centers, that's teaching hospitals specially. So we are you would be able to refer the patients to them and establish the genetic diagnosis and do the genetic counseling done, right? But you yourself, as the practicing doctors, even if you are a MO, you can do good genetic counseling, because there are the very comprehensive resources out there in the lab, right? So the one thing so that have been extensively used even when preparing this lecture, because we can't remember it all, right? So we can't do that, right? So and there is no need to remember everything because the information is out there in fingertip. So I tell it even for my students nowadays, because I am a teacher in anatomy, right? We don't expect the students to remember all these small information that we remember as students, right? Because there's no real need of that, because it's there. If somebody asks, if you have a internet connection and a good phone, right, mobile phone, you can just search for the information. And this one, the gene reviews, right? So that is very comprehensive, right? So it is not just the genetics, so that will regarding any genetic condition, so it will give a very nice um, outline of the things. For example, I just before this test, I just typed the familial hypercholesterolemia here, and this is what I got. So it has all these information, how it is diagnosed, what are the clinical characteristics, what are the other related disorders, right, which appear like hypercholesterol, familial hypercholesterolemia, the differential diagnosis, how it is managed, what to do when you counsel the patients, what to tell them, what are the genetic tests, right? So all that information is there, right? So when you do this test, what is the percentage of patients that you will detect? So all that information is there. So yeah, and this is usually updated very frequently. So every almost all the articles. So I can guarantee they are updated within at least last 4 or 5 years, right? So so you can see this one is updated in 2022, right? So so all these information is there, so you can just so if you get a patient, so even what I do is when I have a patient with these genetic disorders, I just tell the patient, just wait, I'll check it and tell you, and patients like it, right? They don't take it as a bad thing. They really like when we refer to the standard sources and tell them the exact thing. So you can just refer to these sources and it will give all the necessary information, right? How it is inherited, and especially, so all these reports as a part of the genetic counseling as such. So you might need to refer them always for the specialists, right, to do the genetic counseling, right? The another source is this OMI, right? So online Mendelian inheritance on in man. So, for example, I just before this lecture, I just checked for the hemophilia, and this is the first screen that I got. So it just listed it. So list of different conditions, right? So the list continues, right? So you have the hemophilia B, hemophilia A, the related disorders, and you can just click on the disorder that you need to think, and it has all the information that you need, right? So you can just go on and see. Uh, uh, so here you can see what it says: the description, nomenclature, the clinical features, other features, biochemical features, inheritance, diagnosis, mapping, molecular genetic, right? So all this information is there regarding. So these two are very useful, right? So the OMIM and the gene reviews, right? So uh, until now, I didn't find any condition that is missing in this, right? Of course, there might be some disorders which are not listed in this, but all the common things are there. So you can use these resources to get the information regarding the genetic disorders, right? So yeah, so that is, yeah, I have been talking about for 1 hour and 20 minutes now. So I hope that I have told you some useful information about the diagnosis of genetic disorders and the genetic testing in our setting, in the Sri Lankan setting, and the different diseases, the different tests and the resources. So yeah, so that's all that I would like to tell. Right, as I told you, this is a very vast topic. I just brief on the main things, main common conditions only. Right, so if you need my contact information, my emails and the mobile is here. So you can just note it down and yeah, just contact me, right? Yeah, so that's it. If you have any questions, I'm happy to answer them. Right?
Sir, I have a question.
Yes,
Yeah, as you told, sir, there are various screening and diagnostic tests for trisomy disorders, including Down syndrome. Such
mhm,
as you told, maternal serum studies with NIPT and all those things.
yes,
Yeah, that is actually it is the primary responsibility of the obstetricians and the geneticists to
yes,
investigate those things. But sir, as primary care physicians, we should also be aware about these testings and about their timing, especially when it comes to counseling the patients and all. So,
yes, yes.
sir, would you be able to provide a brief overview about the timeline? I mean, the POA, those tests should be performed.
Yes, yes. As I told you, so generally, about the prenatal testing, what is practiced in our setting is the amniocentesis. So the patient should be at least 15 weeks pregnant to do that. But the one that I tell, the non-invasive prenatal testing can be done even earlier. So by even at 10 weeks, right? So that can be done. So that is another good thing about that. So the couple can take a decision early, right? So about their pregnancy, right? And that is less invasive. And I told you that when we think about the cumulative cost sometimes also that would be beneficial. So this is not advertisement. I'm not in that, but I'm just telling the good sides about the NIPT. So it is so the non-invasive test it is 10 weeks, right? And for the amniocentesis it is 15 weeks.
Okay, sir. And sir, regarding the translocation, as you have shown in one of your papers, the risk of inheriting a translocation from paternal chromosomes seems to be much lower than from maternal chromosomes. So, what is the reason for that?
Yeah, if a father, so that is what I said. Uh, if there is a structure, what has been observed, so is that if there is a chromosomal abnormality in a father when he produces sperm, so during the spermatogenesis process, there is a spermatogenic arrest, right? So usually not always, but very commonly the father or the males with chromosomal disorders are subfertile. But in case of females, if when there's a structural chromosomal abnormality like a translocation, even with the translocation, the oogenesis process continues and they produce oocytes with this abnormal chromosomal composition, right? So uh, so usually when embryo or a fetus is produced with abnormal chromosomal composition, usually this chromosomal translocation, very commonly we see that is inherited from the mother's side, right? But that is not always, right? So don't always blame the mothers that it comes from the mother's side. So we see the others, but there's a genetics reason for that, right? So if there's a chromosomal abnormality in the father, so there is a arrest. So there is a subfertile. So they will not contribute their abnormality to the children because they are not producing sperms, right? But the mothers they will send it through their oocytes. So that is the reason. I hope I think I answered
Yes,
your
sir.
question.
Yes, thank you, sir.
Yeah.
So, in the absence of any more questions, I think we can come to the end of the session. I would like to extend my heartfelt thanks to Professor Sampath Paththinige for his invaluable presentation. And on behalf of our college, I would like to thank him. Sir, so your expertise provided us with a very deep understanding about this complex and very critical field. So thank you once again for your time and for making this session so informative. Thank you, sir.
Thank you so much. You're welcome. Good night.
Good night, sir.